to be here with us.
Okay. Where are we now? Uh-oh.
So,
are you still seeing me? Let me see where.
Very well. You are very, very conspicuous. Very.
Okay, because
Very.
let me see. Because I'm on a phone. I've never done Zoom on a phone before, so.
Okay. But I think it's okay. You can see it very well.
Okay. That's good.
So we're going to start. Dr. Oloyede. Yes, I want to welcome our district governor, Rotarian Dr. Oluwole Kukoyi, and of course our revered PDG, Adeni Jiraji, who handed over the leadership of this Southwest Reproductive and Maternal Child Health Action Group. You are most welcome, sir.
Thank you.
Yes, sir.
Let's see what is there.
So, lady, please can we start off? Dr. Oloyede, you are most welcome to this program. You are the coordinator, and we must be stickler to time. I don't think we'll need to wait and get the crowd in. So probably we should start off now, or what do you think?
Well, good morning, my past the governor coordinator. I think I want to appeal for just 5 minutes wait to allow some others to join us, just 5 minutes max.
Okay. I think they are joining in.
All
yes,
right.
may I also humbly welcome National Coordinator of Reproductive, Maternal and Child Health Action Group in Nigeria, Professor Emmanuel Lufadeju. You are most welcome, sir.
Thank you, ma. Thank you very much.
Good morning, sir.
And let me also quickly apologize to every other participant here now who are coming very promptly. We are really very sorry. Just to allow for more participation, please just give us the next 4 minutes and we kick off. Thank you so much for that.
That's all right. Bumi, you can share your screen and put the. Please share your screen and put the headline on the screen.
All right, I'll do that right away. Good morning.
Morning, Dr. Dashit. Good morning.
I'll need permission from the host to be able to share my screen.
All right. That's okay.
I will ask the IT person to give you that permission. That is only if you can get to know your details. Who is speaking, please? Or requesting for
Olubunmi Afolabi.
Olubunmi Afolabi. Let's see if we can. Oh, very good. Okay, I'm going to pass a number to you now, and I hope the IT is also very good. Very good. You've been giving that right. All right. Yeah. But we have to come in at the appropriate time. We also quickly apologize to the district governor, 911 who has come in now. We have just 3 minutes delay before we kick off. Apologies, sir. My Rotarian brother, can we still pull down the slide now until that time so that others can come up before you? Thank you so much.
Hello, good afternoon.
Hello, good afternoon, Prof.
I am Professor Dr. Satish Damankar from India.
Yeah, we can see you live and clear directly too. We just request for just 2 minutes before we kick off. Just about 2 minutes before we kick off, you'll be given the sharing right or the co-hosting right to be able to share your slides at the appropriate time. Thank you so much.
Am I audible?
Lizzie, can you please share the program on the screen now? Lizzie, please share the program for us to be guided.
Save this screenshot.
Okay, at this time, we might want to start the program. Having waited for others to join us, I believe with time they are going to join us shortly. Distinguished participants from all over the world, it is my pleasure to welcome us all on behalf of the chief host and the past district governor, of course, well known to us, Rotarian Omotunde Lawson, and the chairman of this membership committee of RMCH to this particular program. The team, as you all know, is membership to drive maternal and child health services. And we're extremely glad to have in our midst this morning or this afternoon, very eminently qualified Rotarian leaders to serve as facilitators for the program. Permit me to quickly recognize those who are here now, starting from the district governors of 911 and 912, namely Rotarian Dr. Wale Koyi and Rotarian Femi Adenekon, respectively. Also, the national coordinator of RMCH, Professor Adedolapo Lufadeju, as well as the chairman of the Little Steps Big Help projects, our own respected Deputy Governor Nijiraji. In the same vein, I also want to acknowledge the presence of international resource persons drawn from South Africa and India, in the persons of Professor Stella Anyagwe, past district governor, as well as past assistant governor, Professor Satish Damanka. And in the same vein, I recognize the presence of our own past assistant governor, Bumi Ibitoye from Ekiti State. At the appropriate time, they will be properly introduced for us to get to know who they are. So that is just what I've just done, is just a brief recognition. My name is Femi Oloyede. I am actually an assistant professor of fetal medicine and genetics at the Labs University Teaching Hospital, and I've been a past president of District 910, and a past assistant governor, District 910 as well. Served in various committees in that district, now 9111. I am also the chairman of Ogun State Membership Committee for this particular committee, membership committee, and also the chairman Lagos State for the project Little Step Big Help under PDG Engineer Nijiraji. It's my pleasure to welcome us all here. I quickly go straight to particularly welcome and introduce a distinguished person in our presence, and who, by the grace of God, is the zonal coordinator for our zone, Southwest Zone in Nigeria. She's a successful educationist for over 40 years, having paid her dues in Lagos State, and sadly retired in 2017 into another successful private school business. Of course, like I said, she is the coordinator of Reproductive and Maternal Child Health Action Group, Southwest Nigeria, a member of Rotary Club, that's in Lagos West now. We actually have served as club president over a decade ago and moved to the district level to serve consistently and meticulously in various committees, and then eventually as stand governors for several years. Now she has to her credit the record of having been the 42nd and the first female district governor of District 910, that are giving back to 9111 and 912 now, and as is a multi-award winning past district governor. Currently, she serves as assistant regional coordinator in region 27, zone 22. Of course, she is the level 2 major donors. She was given this role about 3 years ago, and honestly, the membership committee has grown in leaps and bounds in the Southwest, both in terms of project support as well as membership. She is actually being behind this particular conference we are having. And to put it on record, this is the first of its kind again in the history of RMCH Nigeria. We are delighted to have you in our midst, Rotary and Anthony Lawson, and I therefore welcome every participant present now as we listen to our own zone coordinator, a distinguished Rotarian par excellence, Omotunde Lawson, to take a speech and also declare this conference open. Lawson, over to you, man. Can we have Rotarian Lawson, past district governor and coordinator, to please take the center stage?
I think you're muted, man.
Very good. So we have Rotarian Lawson, our own zonal coordinator, and PDG to please take the center stage. Over to you, man.
Thank you very much, Dr. Oloyede, and the coordinator of this special program. Distinguished Rotary leaders, speakers, and participants, good morning. I am delighted to welcome you all to this very first conference of the Rotary Reproductive, Maternal and Child Health Action Group Southwest Chapter, which is coming today at the tail end of Rotary's month of maternal and child health. Going by the different public image tools adopted by different clubs globally, a lot of projects have been executed so far with a lot of enthusiasm and commitment to the citizens and communities we serve. In Nigeria, maternal and newborn mortality rates are among the highest in the world and comes third in Africa after Sudan and Chad, with maternal mortality rate ratio of 1,047 deaths per 100,000 live births. Advocacy and sensitization are required on child spacing, family planning, healthy nutrition in pregnancy, personal hygiene, and care of the newborns. If we are to take these steps, those categories of women who are susceptible to this kind of misfortune will definitely get a lot of benefits. Therefore, we must explore appropriate avenues for dissemination of information and education, especially through community dialogues in our local and rural communities. So far, we have success stories to tell of maternal and child health projects as executed in Nigeria as a country, as will be highlighted in course of this seminar by Professor Emmanuel Fadeju, and specifically in our own Southwest by past Assistant Governor, Dr. Ipitore. The essence of this forum, therefore, is to get the interest of both Rotarians and non-Rotarians to be part of the clarion call for good maternal and child health in our country. RMCH Action Group functions in 6 geopolitical zones in Nigeria. And each zone, namely North Central, Northeast, Northwest, Southwest, Southeast, and South-South. And each zone is charged with the responsibility of recruiting members into as advocates who can either be Rotarians, Rotaractors, and non-Rotarians. Definitely, more people are required to join the action group so that we can extend the advocacy of safe birth and motherhood to all the nooks and crannies of our community. Southwest has taken the lead in membership recruitment, and I've got the interest of community leaders and traditional rulers to be part of Rotary Community Corps, so formed for this purpose. Hopefully, many will join us after listening to our speakers and at the end of today's seminar. At this juncture once again, I wish to welcome all our speakers as Sadia introduced and all participants online. And I have the honor of declaring the conference open. Thank you very much.
Yeah, can we give a round of applause, please? Thank you so much, District Governor, past District Governor, and the Chairman of the zone. With that tone of setting the conference open, it is my pleasure to now call on Rotary Otun. He is there to quickly take over the introduction of the next speaker.
Distinguished participants, distinguished guests, PDGs in our midst, district leaders in our midst, district governors in our midst. I want to quickly bring on board the next speaker. My name is Olalekan Otun. I want to quickly bring, I'm your compare for today. May I quickly invite the RMCH coordinator, Professor Aigolako Fadeju, to deliver his presentation on reproductive, maternal, child health care and national health development in Nigeria. Professor Fadeju, you are welcome, sir. Please, a round of applause for Professor Fadeju.
Thank you very much, ladies and gentlemen. It's a very wonderful morning in Nigeria. The weather is quite friendly and cool this morning. I have a lot of people to appreciate on this platform. First is to Ayaba Losin, past district governor, who is the RMCH coordinator for the Southwest, for bringing this webinar into being. Thank you very much, Ma, for your dedication and your active support of RMCH activities. I also want to thank my very good friend and brother, past district governor Jiraju, who was initially formerly the coordinator for the Southwest until we project in the Southwest for him to lead, and he's leading that project on malaria and nutrition in young children in Nigeria. That program is in Lagos, Ogun, and Oyo State. You are welcome. Let me also welcome our two governors. Wale is very known to me. DG Wale Kukoyi, you are very welcome to this meeting, and I appreciate your support for RMCH.
Thank you, sir.
And also DG Adelekon, who is in the 9112. You are both very welcome, and we hope that your support for this program will be highly sustained in future years. I also want to thank Oloyode for all his communications with me and all the support she's giving to our very hardworking zone coordinator, Ayaba PDG Lawson. Permit me to make this presentation in two formats, and we are going to be very succinct and brief. I will give you a brief history and how we got to the program of scale and our implementation strategy. And the RMCH program, Together for Healthy Families in Nigeria, Communication Officer, Mr. Bumi Afolabi, will now give you a little bit of detail of the program of scale and what we have achieved so far as an update, so that everybody will be up to date on our activities. Thank you very much. Let me start by saying that RMCH started very small. We started a project in 1995 called Child Spacing and Family Health, together with my colleague in Germany. His name is past District Governor Robert Sinza. He's going to 98 in this October, 98 years, and he's still kicking and doing very well. We started in 1995. We did a project in 2 local governments, in Zaria and Saminaka local government between 1995 and year 2000. And we had 4 pillars, as a matter of fact, for that project. It was contraceptive distribution, capacity building of health personnel, public awareness campaign, and also institutional strengthening by distributing equipment, consumables to primary healthcare centers and secondary health hospitals within the project area. In year 2000, when the final evaluation of that first small project was conducted, one of our indicators at that time was how many women are using family planning, how many women are using contraceptives. And when we started, we took a baseline in 1995. By year 2000, when we did the final evaluation by an independent organization from Germany called DSW, we had increased contraceptive prevalence rate from 3% to 27%. Don't forget that Nigeria is still struggling to reach 30% in year 2030. I'm talking about 1995 now. This result excited Rotary Foundation so much that they granted us what we call a 3H grant, Health, Hunger, and Humanity. For those who have been in Rotary for long enough to know what that means. It's a program that is given to the topmost program worldwide, and we got that program, we got that award, and that award was in line with the first matching grant, the same 4 pillars, and we got the same result. And one of the things that we did was we made the government, the state government, to create more primary care centers so that we brought the primary care centers closer to the people. Today, we are still growing primary care centers and upgrading them, but we started in 1995. So moving on very fast, this is a program that has gone through all the grant format of Rotary Foundation. Matching grant, 3H grant, close to 15 global grants, and now program of scale. So it is now recognized as one of the flagship projects of RMCH. RMCH started as a Rotarian initiative for population and development. In fact, it started as Rotarian Fellowship for Population and Development. Then, some years later, it became Rotary Fellowship for Population and Development. And about 10 years ago, it became the Rotary Action Group for Reproductive, Maternal, and Child Health, RMCH. Between 2005 and 2008, we conducted a lot of projects, especially on vesiculovaginal fistula, repairing them, rehabilitating them, teaching them skills, and bringing them back to their communities, because normally they are ostracized. And that VVF is a condition that is brought about when delivery is by very young people whose pelvic has not yet well developed, 12, 13 years old, and they have obstructed labor. And that way, the reproductive tract gets kind of injured, and they have what we call urinary and fecal incontinence. It's a very terrible condition, but we did a lot of surgeries in those days, and we did a lot of rehabilitation and vocational skill acquisition. Moving forward, 2008, our German counterparts advised us and recommended us to conduct a project on quality assurance in obstetrics. Quality assurance in obstetrics is a very simple process. We are talking about quality of structure of our facilities, how many doctors, how many beds are there, do they have enough equipment, the operating theater, is it working well? And we did this in 5 states, later developed to 8 states, and we included hygiene and nutrition in 2008. When we did the evaluation of this program in 2013, by doing these 4 pillars and adding nutrition and hygiene in about 65 facilities in the country, in the states of Kano, Kaduna, the FCT, Ondo, Enugu, and later Ebonyi and Osun State, we have been able to reduce maternal mortality by 50% and infant mortality by 15%. These results are published in the Journal of Gynecology that we can reference for those who are interested. So, at the same time as we are doing the quality assurance in obstetrics, which is quality of structure, quality of process. What happens when a woman gets pregnant in the community and wants to access the facility for delivery? Transportation, fund problems, behavior of health staff, discouragement of communities, and so on and so forth. So we end up having more than 70% of childbirth occurring in the home. Some of them not under skilled healthcare professional. And therefore, a lot of maternal mortality occurs through 4 main processes. The first is postpartum hemorrhage, PPH. That is bleeding during childbirth and also after childbirth. The second is eclampsia, which is high blood pressure during pregnancy. And then we have sepsis, ordinary infection that can be taken care of by antibiotics. And of course, we have abortions, incomplete abortions, and abortions performed by unskilled personnel. These 4 conditions are the major causes of maternal death in our country, Nigeria. And believe me, they are all preventable. That means we don't have to suffer them. Our women do not have to die because of these conditions. And then we talk about the quality of the outcome. What is the outcome of this birth? Is it a twinning? Is it a stillbirth? Is it a macerated fetus? Many children have died, have been condemned to death because they were not able to breathe initially they were born. And they can easily be resuscitated, helping baby breathe. It's another aspect of this program. So you can see this quality of structure, quality of process, and quality of outcome were being studied during that program, and we were always improving them and making sure that things are getting better. At the same time, the federal government of Nigeria started what they call Maternal Perinatal Death Surveillance and Response, MPCDSR. This Maternal Perinatal Death Surveillance and Response is a recommendation of WHO to make maternal death audit in every country in the world. Let me explain to you that when a woman dies in any hospital before Rotary's intervention, nobody knows where the death has occurred except the doctors and the families involved. Some of these deaths are concealed, some are blamed on doctors, some are blamed on all kinds of things, but no records are kept. When Rotary came in with this support for MPCDSR of the government, we established what is called the electronic platform, which is NOCA platform. NOCA platform is a web-based data management process that can allow us to look at where death has occurred in our facilities in the country. And these deaths are notified within 24 hours. And where the death occurs, it has to be reviewed within 30 days. And this is called MPCDSR. In our country now, is a federal government policy. And the tool to measure it, which is the electronic platform, has been adopted by the federal government of Nigeria through the Ministry of Health. So you can imagine how many medical record officers of facilities have been trained? Thousands in all the secondary hospitals and the primary hospitals in the country. We have also trained a lot of 734 monitoring and evaluation officers in the local government of Nigeria to learn how to use this facility. You collect the data on your telephone system and in the facility or in the local government, and you press a button. The data is automatically transmitted to the state statistician, HMIS officer, who presses a button on the system, and it is sent to the federal statistician. All this cadre of staff have been trained by RMCH over the years. For the past 5 years, we have been doing this capacity building, continuous training and retraining. Hello? Are you hearing me?
Yes, we can hear you, Prof. We can hear you.
Okay. All right. So it's been going on. The capacity building has been going on for about 4 or 5 years. And by the time we asked the government to let us work together. They gave us a mandate for 3 years to work together with the Federal Ministry of Health. And through that process, we have been working together to develop MPCDSR, establish it properly in all the states of the country, get maternal data that is reportable and notifiable, just like cholera happens in our communities. So today, maternal health, thanks to Rotary RMCH and the Rotary Foundation for this opportunity. Now, you can see the history. When we put this history together, we did what we call a national family planning project, which lasted for 3 years. 3 years, and this was the vehicle through which we trained so many providers, so many nurses and midwives and doctors and nurses who are trained under the National Family Planning Program. And we use this program to also strengthen MPCDSR nationwide. When we put all this history together and we applied for the program of scale, Rotary said, undoubtedly, this is a program that we can support. It is scalable, it can be expanded, and we can support this program not only to spread through the entire African continent, but also to spread into Nigeria and other countries surrounding us. So in support of this program, two things are very important. Advocacy, which is a very big component of this program, to advocate at very many levels, at the government level, at the community level, at the local government level, primary care level, and also amongst professionals, to bring down maternal death in the country. And the program of scale, as my communication officer is going to explain to us very briefly in the next few minutes, is to make sure that this maternal mortality is reduced drastically, and we are able to measure it, and we are able to use the measurement and the result we get for planning, for budgeting, for prevention of maternal death, also, and for helping mothers and children. That is advocacy that goes on nationwide. And luckily for us, I am the chairman of the Federal Ministry of Health, Safe Motherhood section, the chairman of the technical working group of Safe Motherhood, under which MPCDSR, family planning, reproductive health falls under. And we meet every time, quarterly, get support from other partners who are working with us, like SOGUN, Pediatric Association of Nigeria, and consultants of very high repute, like Professor Shitu and Professor Adiza Galadanchi, asked in the techniques and activities that can be performed to reduce maternal and infant mortality. And lastly, let me mention to you that for sustainability, RMCH proposed a bill to the Nigerian legislature through the Senate with the support of the Federal Ministry of Health and SOGUN. And we got the bill passed by Senate about a year ago. That is the bill to enforce MPCDSR nationwide and to use the electronic platform that has been introduced by Rotary nationwide in Nigeria. And that bill is now undergoing concurrent approval by the House of Representatives, and subsequently it will go to the President for signature. That is where we are on that at the moment. It's all to sustain the program and make sure that the thing is not thrown outside the window when the program started. Briefly, I will ask Bumi Afolabi to just expatiate a little bit about the program of scale and the achievements so far. Thank you very much, ladies and gentlemen.
Thank you so much, sir. Can we applaud President Fadeju, please, very quickly? Can I seek your indulgence, sir, and your kind permission that the next presentation now should be taken together with that of the Ekiti coordinator for program of scale, especially because the next speaker we have to exit at a particular time, and we don't want to keep her waiting.
Thank you very much. Thank you very much, Dr. Oloyede. That was what I was just about to say. That because the time is already on the timetable, therefore, we actually need to be conscious of the time.
But at a point in time, I think we should listen to the progress update.
Yeah, we will definitely, sir. We will definitely. We will definitely. All right. Thank you so much once again, Professor Padeju, for that insightful and educative presentation. We always appreciate it. The next speaker, please, return to 1 second.
Called Dr. PDG Engineer. So please take us through the next topic, which is achieving maternal and child health through little steps in a project. Thank you very much for coming on board, sir. So you have the floor, sir. Thank you, sir. Please read the profile briefly.
Distinguished participants, distinguished guests, ladies and gentlemen, as a charter member, joined as a charter member which comes from Bagada in 1984. He became district governor. He has served the club as president 1988 to 1989 and the district governor in 1997 to 1998. He's a member of the Action Group for Reproductive, Maternal and Child Health, RMCH, and he has led global grants aimed at reducing maternal mortality and morbidity through capacity building, that is training of health workers. He is currently involved in tackling malaria and malnutrition in mothers and infants in Southwest Nigeria, majorly Lagos, Ogun, and Oyo states. He's a level 2 major donor to the Rotary Foundation. He has received many awards and medals, such as the Rotary Foundation Service Above Serve, Rotary Foundation Citation for Meritorious Services, and the Foundation Distinguished Service Award. Distinguished guests, ladies and gentlemen, the chairman also of Little Steps and Big Air Project, PDG Adeniji Raji. You are welcome, sir.
You have the floor, sir.
PDG Raji, please. You have the floor, sir.
Yes, sir. Or is it muted? Please, can you kindly check whether it's muted? Yes, it's muted. Can you please say something? Ask him, please unmute yourself, sir.
Okay. Thank you very much, the coordinator. I'd like to acknowledge the presence of our two pioneer district governors, Dr. Kukwai and Femi Adenakon. And of course, I also like to acknowledge the presence of our national coordinator, Professor Lufade. There's no way we talk about maternal and child health without mentioning Professor Lufade, being a co-founder of RMCH and has been involved since the beginning. I don't know whether you want to show my slides. Actually, part of my first of 2 slides actually talk about the progress we have made so far in maternal and child health. But we all know that the well-being and the health of mothers and children is proportional to the prosperity and progress of any nation. So, because they dictate the future of our new generations and of society. So this, our new project, which is an upgrade of our previous project, which is capacity building for training doctors, nurses, family planning providers in Lagos, Ogun, and Oyo states. I don't know whether you have the slides. I don't know whether you, or can I show the slides and control it myself, please?
Please go ahead, sir. Please go ahead, sir.
Okay.
Thank you, sir.
All right. Just give me a minute. Okay. I will skip many slides which are not because of time. Just give me a few minutes to get to the beginning. Well, okay, we are all aware that Lagos, Ogun, and Oyo have a lot of malaria prevalence. I will show the figures later on, but you can see 25% of global malaria cases worldwide are in Nigeria, and 22% of children are underweight. So that's a problem in Lagos, Ogun, and Oyo State, and I presume in the whole of the Southwest. And malaria remains the foremost public health problem. It takes its greatest toll on children under 85 and pregnant women, especially in rural areas. Also, estimated 2 million children suffer from acute malnutrition. Let me just, because of time, let me see the impact. What are the impacts of malaria and malnutrition on mothers and children? Malaria infection during pregnancy have very adverse effects. One, they have maternal anemia, not enough blood in their body. Sometimes it's also responsible for fetal loss. They can lose the baby. And sometimes for premature delivery, PREM, and many PREMs have the risk of dying prematurely. They also have intrauterine growth retardation. Of course, delivery of low birth weight infants. Low birth infants are at risk of dying early. Although malnutrition also increases the severity of malaria. If you are malnourished, malaria will be very severe. So malaria and malnutrition are twin brothers. If you have one, you are more likely to have the other. So it is important. That's why we address malaria and malnutrition, both in mothers and in children. Well, I just give you some statistics that we got from Oyo State. The prevalence rate. In fact, Oyo State is the epicenter of malaria in the Southwest so far. You can see in Ibarapa North, a population of 168,155, 76.8% have malaria, our malaria. So, and that is very common in Oyo State. Of course, we also have similar prevalence in the Ogun and Lagos State, particularly in rural areas, Ibejuleki, Badagry. You have many of those high prevalence rate of malaria. WHO says in Oyo State, 38% of children are malnourished or have stunted growth. And that's very, very problematic. And that's why this project, we are concentrating 60% of the effort and the funding in Oyo State. We are addressing 96 primary health centers in Oyo State in 15 local government areas because of the prevalence of malaria and the prevalence of malnutrition. What are the key areas that we are going to be addressing this? We have 4 thematic areas. The first one is training of doctors, nurses, and community health workers on malaria, malnutrition, the screening and treatment. That is key. Up to date, we have trained almost 317 health workers. That's the first phase of the project. The project is a 3-year program, and it's supposed to end in 2026. So that's first thematic area is training of doctors. The second is equipping health facility with first stock of medical drugs. Many primary health centers don't really have enough drugs either to test malaria or to treat malaria, even malnutrition. I mean, things like tapes to determine malnutrition stage of a child, some don't have. So we are going to supply drugs to all the primary health centers, but primarily we are going to utilize some of those during our outreaches. The other area is we are going to have health outreaches through CHOOSE. We are going to have about 4 types of outreaches: community outreaches, antenatal, school, and primary health center outreaches, in which case we not only educate people about the myths and misconceptions about malaria and malnutrition, because sometimes people think, well, once I have fever, it has to be malaria, I go to the pharmacy and I buy medication. So people have to be their minds have to be abused of how to address that. The other part is the health outreaches, where we are going to train people. We are also going to test, and we are going to test people at, why is this man calling me? I'm online now. What do you want? The last part will be the social behavioral that we are going to be having jingles on radio in 3 languages, English, Yoruba, and Pidgin, telling people about malaria, what they need to do, and about malnutrition. Of course, during the outreaches, we are also going to do food demonstration, because not because you eat amala every day, it's not nutritious. We're going to demonstrate to people what they can add to our local food to make them nutritious. That's the kind of complementary feeding program that we will do. What are the outcomes? What do we expect to get? We expect by the end of the 3 years that medical staff will have better professional services in preventing, diagnosis, and the treatment of malaria, as well as nutrition. Women and children with malaria and malnutrition have been detected and are treated, and they also know where to go when they have malaria or their children are malnourished. More households with mothers and children will use insecticide-treated nests. We have 15,000 ITN to distribute during our outreaches to mothers and to homes, and to tell them how to use them, because many of the families really don't know how to use the nets. They think it keeps them too warm. And also, I mean, nets only keep people out of mosquito bites in the night, we also advise them what to do during the day, like using cotton, like cleaning their environment and all the rest of it. Well, these are the participants. This is the coverage area of the project coverage. In Oyo State, we are going to do 96 primary health centers in 15 LGAs. In Ogun, we are going to do 30 primary health centers in 6 LGAs. And in Lagos, 34 primary health centers in 5 local government areas, giving a total of 160 primary health centers in 26 local government areas. Up to date, these are the people we have trained so far in Lagos, Oyo, and Ogun states. And these are, we did a baseline studies to know what this exact situation is, so that at the end of the program, we'll do an MIE to know what impact our project has done. So those are just some of the pictures that have been taken, but let me just go to the last part of it, which is, those are the outreaches, cluster outreaches, school-based outreaches, infant welfare outreaches, and antenatal outreaches. Sorry about that. I shall soon be done. I just want to show you some of the IEC program. These are typical IEC program. We have flyers when we have these outreaches about malaria, do not abuse malaria medicines, malaria alert, malaria is killer disease, can be prevented, test before you treat. And we also have for feeding, flyers for feeding, how to breastfeed your baby, what you need to know about breastfeeding, how to help attach your breast, all those part of the class that we'll give during the outreaches. That's all the outreaches. So I thank you for your time. Sorry, maybe I overspent my time. Thank you. I hope
Thank you so much, sir. Thank you so much, sir. You cannot overrun your time. It was just appropriate, sir. So thank you so much. Now, because of time, please permit me to please appeal to other speakers to just see what they can do to present the main points, as it were, in order for us to leave this in a time.
On that note, thank you very much, sir. Let me join Dr. Oloyede to thank you. If we decide to actually listen to go the whole org, in fact, the presentation will even be longer than this. But I know we can always have the slides. I can always share this to all and sundry. So once again, I thank you very much for your presentation. God bless you, sir. Thank you very much, sir. Arriva PDG. Yes. So yes, sir. On that note, we have 2 Google messages to take. We are going to take the Google message from our District Governor of District 9111, Lieutenant Dr. Wole Okoye, for 2 minutes. You have the floor, sir. Our District Governor. Please, you can unmute yourself, please. Unmute yourself, please. Okay, while waiting for him, okay, all right. I've gotten a message, he'll be back. He'll be back. So let's go on and take DG9112. I've not seen him online though. So while we also expect him to join us, may we quickly go on to the next presentation, which definitely will be joined in 5 minutes by the Ogun State Coordinator for RMCH, and the coordinator of this program, Dr. Olufemi Oloyede. Please, you have the floor.
Yeah, thank you so much, my coordinator and PDG. I'm going to be talking in the next 5 minutes very quickly on the subject of maternal and child health statistics in Nigeria, where we are. I'm going to start on the note of reminding us that the world is 8 billion, made up of equal proportion of males and females. It is therefore a fallacy to say we have more females than males worldwide. But what is more important here is that we need to pay attention to the women that are between 15 and 44 years, that consist of 65 million, as well as out of the 2 billion children worldwide that are under 5. These groups are peculiar because of their anatomical disposition, and the fact that in the under 5 children, the immunity is really still low for them to cope with a lot of extraneous factors. On that slide, which is being shown now, you will see that about 6 countries contribute significantly to the world population. And of these 6 countries, 5 of them are actually in Sub-Saharan African and Southern Asia. And that's very instructive. The second slide there is actually telling us about the total deliveries worldwide. Out of 150 million deliveries every year, or about 385,000 daily deliveries, we found out that Nigeria constitutes about over 5% of those total deliveries. And of the 140 million, about 5 countries again donate this 140 million to the world. These countries are completely in Southern Asia, as well as Sub-Saharan African countries. And the 5 countries are shown on the slide. The next slide, therefore, is to now ask ourselves, what are these indices that reflect the health of the mother and the children? Like I mentioned earlier on, for the mother, we'll be talking mainly about maternal mortality, those who die during pregnancy or within the first 42 days of pregnancy. All over the world, we have the records that shows that about 295,000 women die every year. This gives us an average of 810 per day, women dying because they are either delivering or they are participating in their natural cause. Now, can the IT please share the screen from there? I understand the screen is not being seen, but I will still keep talking while we are waiting for the screen to be shared. But in Nigeria, what do we have? Out of the 810,000 that dies every year, about 57,000 of them are from Nigeria. That means that Nigeria contributes about 20% of global maternal death. That is very instructive. And about 1,000 people die in Nigeria, women die in Nigeria every week. That gives us about 142 women dying every day in the nooks and crannies of this country. If we divide that gives us about 3 or 4 from each state on the average. Now let's take a minute and pause on these statistics. If you lose 142 women, mothers, children, our wives, because they are performing their God-given roles every day in this country, it's not a static and gloss over. That can be put to the size of an aircraft leaving from here, Lagos, to Kano, Abuja, and others. And if each plane drops every day, and we have 142, then it means there is a huge problem on our hands. They are largely unsung because they belong to a social strata that are rarely recognized. But as Australians not begin to bring this to the forefront, and that's what we are doing today. Now let's look at the indices in the children. There are 3 major indices we are going to consider: neonatal, infant, and under 5. And that slide is just showing us the performance in children of their health in Nigeria and globally. Please go ahead. Just change the slide, please. Change the slide. Now, if you look at it, for a child that is delivered to still live up to 28 days after delivery, globally, about 12 of them will die out of 1,000 live births. But look at the situation in Nigeria. We have almost times 3 of that global average. About 35 will die out of every 1,000 that will deliver in Nigeria. That puts us in an unenviable position of 6th all over the world. And if you are looking at 6th position from the rear, that is not good enough. Let's look at those who die between the time of delivery and the first year, never attain the first year. Globally, an average of 20 would do that. But in Nigeria, over 3 times this number would die because they are born in Nigeria and they will never get to the first year of life. The same thing we are looking at under the under 5. That is, after delivery, those who survived to their 5th birthday, globally about 37 out of every 1,000 that is delivered would not get to the 5th birthday, celebrate the 5th birthday. But if such a child is delivered in Nigeria, as well as other countries in the low and medium economic countries, about 3 times this or more, 117 would not live up to the 5th birthday. Now look at the ranks. We are number 6 globally in neonatal death, number 3 in infant death, and number 3rd in under 5 deaths. These are not sharing news at all. And the next slide are just showing us how the countries perform or the countries involved in these indices. The neonatal one shows that Pakistan, Afghanistan, Lesotho, Somalia, Niger, and most of them are actually 3rd world countries, as it were, especially sub-Saharan African. If you look at the countries that are actively involved in the infant mortality, again, Sierra Leone, Nigeria, Somalia, Chad, Ghana, Guinea, and all the rest. These countries are majorly countries in Sub-Saharan Africa and then Southern Asia. And when we now look at the slide that shows the under 5 mortality globally, you see again that the majority of them are countries in the Sub-Saharan African region and Southern Asia. Now, the key facts from what I've said so far, therefore, is that out of the estimated 5 billion people that died from largely preventable conditions that we have been told this morning, preterm deliveries, birth asphyxia, pneumonia, severe acute malnutrition contributes as an underlying factor in over 45% of them, under 5 deaths. Let me also remind us that most of these deaths occurs in Sub-Saharan Africa and Southern Asia, and the bulk of them are preventable. While the whole world is reducing the indices progressively, yes, we do the same, but not as fast or as rapid as the world is going. Now, let us therefore ask ourselves, what do we need to do to reduce this gap? Because there's obviously a gap. Most of our women are dying, most of our babies are dying in Southern Africa and in Southern Asia. We need to begin to take proactive steps to bridge that gap. We need to reduce cultural inhibitions that may exist that prevent them from accessing healthcare. We need to look at the religious beliefs that sometimes prevent some of them from accessing healthcare. We need to talk about educational improvement. We need to look at transportation and not the rest. All these are things that we can do, especially from the Rotary point of view, when we belong to RMCH, either as members or sometimes as community core, because the community core members are leaders in the community who are closer to these people, and they can therefore bridge the gap between the caregiver and the care receiver in this instance. Finally, let me quickly remind us that the mortality and morbidity, as well in mothers and children, is unacceptably high in Sub-Saharan Africa and Southern Asia. In fact, when you look at it, the countries involved, mainly Pakistan, Afghanistan, India, Nigeria, and some few others, this is very close to the pain that we talk of in polio. And we could therefore also come up with another acronym for this, such that when we can reduce mortality in this, when we can reduce the health indices in this country, we will be improving mortality and morbidity in the mother and the child. It is something that is avoidable, tragedy that we can avoid. We must stop our mothers and children from dying, because as it is now, the country is within the first 5th position in either sector, and it's something we must reverse collectively as Rotarians. I would therefore want to wish all of us on this platform, either we join the Rotary Action Group for RMCH, we encourage community core to come on board so that they can actually bridge the gap and be able to reduce this in this scenario situation. I thank you once again for the opportunity to speak, and I hope we all had a very pleasant time. Thank you.
Thank you very much, Dr. Oluyede, for that. You have told us exactly the reason why we are here. More people to join us, more members to drive this advocacy. more hands to be put on deck so that we continue to reduce the rate of maternal and child mortality. That is the key reason why we are here. And I think so far so good. Justice has been done by the three speakers that we have listened to. Thank you once again for that brilliant presentation. So on that note, I know other speakers have actually waited painlessly, and I want to thank you for that. So the floor is now open to PAG Dr. Satish Damanka from RI District 3170 India, as he speaks on safe motherhood, Rotary's role in achieving it. Actually, he has 15 minutes, but I think he can do it in less than that time. So we appreciate that. So on the screen, we have also please take us through.
Coordinator, please. I
Yes,
want
sir.
us to increase this time to 2 hours, please. Some of us are ready to wait for 3, 4, 5 hours. So don't let us rush ourselves. Please, I appeal. Let's make it 2 hours.
Sir.
Thank you very much.
Well, hopefully that people will not want them to be leaving the platform if it becomes too long. That is the fear we are having. So, okay.
No,
all right.
I don't think you should worry about that. It's interesting enough for people to stay.
All right, sir. All right, sir. Okay, Dr. Satish, you have the floor, please. Please read the profile briefly.
Distinguished participants, we have here with us Dr. Satish Damanka. He's a professor at USM KLE National Medical Program in India. He's a gynecologist and obstetrician with the Centenary Charitable Hospital in India. He was president of the Federation of Gynecologists and Obstetrician Societies of India, first recipient of Reachable, the Vishnu Kamath Memorial Award for improving the maternal and child mortality health care in the district. He helped develop partnership and NGOs with governments and medical schools for addressing health issues of women and school health. Satish Damanka is the president of the Rotary Club, was president of the Rotary Club of Begum in 2016-2017, and AG assistant governor for the year 2016-2017, and is also a major donor to the Rotary Foundation. Ladies and gentlemen, welcome with me on board here, Professor Satish Damanka from India. Thank you very much.
Thank you very much. Dr. Satish, please, you have the floor. Thank you.
Yes. Very good morning to all of you from Rotary Club of Belgaum and Rotary International District 3170. Am I audible?
Very audible.
Yes.
Very audible.
I bring greetings from my district governor, Rotarian Sharad Pai, and I feel that this participation in this first international conference on maternal and child health has been possible because of the Rotary Convention in Singapore, where I met Dr. Olufemi and past district governor Omotun Lawson. I am very thankful to them for giving me this opportunity to share some of our views on maternal and child health and how India is tackling those issues. Can I have my slides? Or should I share the slides?
Yes, if you have those things, right, share this. Okay.
Yes, thank you. Thank you very much. Yes. Can I have the next slide, please? I'm going to today talk on safe motherhood. We have heard that motherhood is a blessing for women, and it should be the fundamental right, or it is a human right of every woman to have a safe motherhood. What does safe motherhood mean? It means ensuring all women receive the care they need to be safe and healthy throughout pregnancy and childbirth. It is a time of expectation and joy for a woman, her family, and the community. Next. To look at the picture, why we need to study about safe motherhood, because maternal mortality is a tragedy for an individual as well as family and as well as nation. 600,000 women die every year during pregnancy and childbirth all over the world. That translates into every minute of every year there is a maternal death. So 99% of these occur in developing countries. So that's how the alarming the picture is. And majority, that is almost 80% of these are preventable by simple steps, which I am going to elaborate, and I am going to say that how Rotary can participate in this project of bringing down the maternal mortality. Next. The theme for the Safe Motherhood, this Safe Motherhood initiative was started by WHO, and the theme this year is empowering families, strengthening communities for optimal maternal health, which highlights the importance of the families and communities that support mothers. Because obstetrics is not just with the patient and doctor. There is a social angle or social aspect to the obstetrics, and families and communities can play a bigger role in bringing about decrease in the maternal mortality. Next slide. So there are these 4 pillars of safe motherhood are very important, and on this foundation the safe motherhood rests. First one is antenatal care, because good antenatal care during the 9 months of pregnancy can convert the high risk mothers into low risk mothers. Next will be clean and safe delivery. So it is an intranatal period. How we handle intranatal period is also essential. Next comes essentially obstetric care, that is postnatal care. And the most important is family planning. Because we all know motherhood should be by choice and not by chance. So we have to promote family planning, and we should encourage women by improving their education and empowering them. We should see to it that they choose the time they want to be mothers. So basic maternity care has to be offered to every woman in the country. And most important, women have to be respected and treated equally in all settings. This will be the foundation for safe motherhood. How India is tackling the issue of maternal mortality. The government is playing a very, very proactive role. In India, almost 60% of the deliveries occur in private sector and 40% occur in government institutions. The government has the capacity to support free transport to the health her accompanying person. There are free diagnostic tests which are needed during pregnancy. Then there is a free normal delivery is conducted in most of the government hospitals. Even when they are in the hospital, they are supplied with food when they are in the hospital. Then free medicines are given and free treatment for the newborn up to 30 days after birth. So the motto of our government is to bring down the maternal mortality at any cost. Next. Next, please. So what are the measures of safe motherhood? As I said earlier, antenatal care, good antenatal care lays a strong foundation for safe motherhood. Early registration of every pregnant woman is very, very important. She can register as early as she misses her periods, or a pregnancy is detected when most of the patients who do their urine pregnancy test at home and come with a positive, when it is a positive test, they visit the hospital or the primary health center. Here, I would like to stress here that we have ASHA workers. They are called as accredited social health activists. And they are the most important link between the hospital or the clinic and the pregnant woman. Each ASHA worker is allotted 200 number of citizens. And in that area, whenever there is a pregnant patient, she develops a very close bond with that woman, and she looks after her health and brings about a good antenatal care for that woman. So we insist on minimum 4 visits to the hospital by identifying high and low risk pregnancies. Here I would like to say that when I was the president of Rotary Club of Belgaum, we adopted one primary health center, and we used to visit every month on first Wednesday. And we used to do every pregnant woman's antenatal checkup. If there was a blood which is to be investigated, we used to do blood investigations. And that brought about, so in 1 year, we saw 400 antenatal women. And to tell you very encouraging results of only 3 women had their babies to be transferred to NICU, that is neonatal intensive care unit. So that's how the antenatal care is important. Then the next point is to strengthen the referral system, because if there is any emergency, immediately the patient has to be referred to the level 2 or level 3 health care. Routine immunization with 2 TD doses, that is tetanus and diphtheria, and supplementation of folic acid, iron, calcium, and protein is very essential, because most of the women, in spite of being rich or middle class, they neglect themselves and avoid taking iron, calcium, and protein, and they are deficient in that. So the supplementation plays a great role in safe motherhood. Then comes intranatal care. All the deliveries, institutional deliveries, are encouraged. Earlier, there used to be a trained birth attendant who used to conduct deliveries in the rural areas. But nowadays, the government has encouraged that all deliveries must take place in institutional deliveries. And to tell you the change which has brought about over a period of 10 years, from almost 50% of the deliveries taking place in the institution, at present, 99% of the deliveries are taking in institutions. At institutions, these 3 C's are very carefully taken care of: clean hands, clean perineal area, and clean umbilical cord. So these prevent infection, and infection forms almost 30% of the incidence of maternal mortality. So we take care of, by just following these simple measures, we can avoid maternal mortality in 30% of the cases. Postnatal care, the support, as I said, family support, financial support, and emotional support is of paramount importance during this period. Because with the withdrawal of the hormones, the woman is likely to undergo postpartum depression. And when she has this support, she is able to tackle the postnatal period in a very significant manner. Breastfeeding, early and exclusive, has to be promoted, because we all know the benefits of breastfeeding in the improvement of health of the neonate. Then family planning services, or as I said, contraception, has to be advised at the time of discharge. And third and most important, safe abortion services have to be provided to all women. In India, Medical Termination of Pregnancy Act is there, and it is the abortion is legalized. But the government has laid down certain conditions where it can be done, when it can be done, who should do it, and how it should be done. So this gives a lot of safe abortion services to the large population, and the deaths from septic abortion have maternal deaths. It is also considered as maternal mortality. Even if the patient dies during the process of abortion, it is counted as a maternal mortality. Next. Next, please. So next is essential newborn care, because clean delivery, resuscitation at birth, prevention of hypothermia and hypoglycemia, prevention of infection, breastfeeding early and exclusive, and referral of the sick newborn to a tertiary level care center will bring down the neonatal mortality to a significant extent. Next. So what are the actions for safe motherhood? There are different sectors which can act. One is health sector. What can be done is basic antenatal, intranatal and postnatal care can be given to every woman who visits the facility. Next is good quality obstetrics care, which is of very great importance. As I said earlier, pregnancy should be by choice and not by chance. Prevention of unwanted pregnancy and unsafe abortion will help in supporting safe motherhood. And regular maternal mortality conferences should be conducted, wherein every maternal mortality should be discussed threadbare, and we should analyze where things went wrong, what things could have been done better, and what things could have been avoided. If these maternal mortality conferences are conducted in every institution or every center, the doctor, the sisters, and the hospital staff will get sensitized, and they will give a lot of importance to bring down the maternal mortality. And most important, as Sir said earlier, past district governor, that periodic refresher courses are of paramount importance, because ultimately our aim should be capacity building. We train the trainers, and in turn, we bring about safe motherhood. Next. Now, what community, society, and NGOs like Rotary can do? Rotary has a major role to play. We can do a big change because we have committed Rotarians who are ready to work and who believe in service above self. And with this, I have some project ideas which can be definitely implemented, say with a district grant or a global grant, and we can bring down the maternal mortality. First is health awareness and health education, where Rotary, community, and society can play a role. Delayed age of marriage of a young girl, that is more than 18 years, should be created. The awareness should be created. Then, what are the risk factors during pregnancy? Health education can be given. Women's empowerment. She should be socially, economically, and physically independent, and that will bring about a great sense of belonging to her in the days to come. Next is skill development workshops. Rotary can conduct skill development workshops for doctors and all the staff of the hospitals. Here I would like to mention that vocational training teams can play a big role in skill development, because there are some examples which can be definitely emulated. We can follow them if they are doing something good, and we can improve ourselves. So skill development programs can be taken up between two countries, two nations, which can bring down the maternal mortality. Rotary can give ambulances or arrange for transport for emergency patients to the hospital. Birth kits and supporting healthcare providers will be also of great help, wherein community, society, and Rotary can play a role. Milk banks. There is a concept called as milk banks, where the milk is stored from different pregnant women who have delivered and they have excess lactation. Instead of throwing the milk away, this milk can be stored in milk banks and that can be utilized for a neonate who needs more milk. This is in our district, we have a milk bank which is installed or which has been institutionalized by spending 80,000 US dollars with the help of global grant. Next is NICU, good NICU facilities or neonatal intensive care unit. We have a cocoon project. Similarly, Rotary has given or established a good neonatal intensive care unit in our district, again with a global grant. And we all know we are fond of pulse polio or polio free world, and we are working hard on that. And it can be extended to extended immunization or against all diseases. This will bring down the mortality in under 5 age group. Next. Next, please. So we all know healthy newborn to a healthy mother is an ultimate reward of an obstetrician. What an obstetrician desires, he desires to have a healthy newborn and a healthy mother at the end of the period of pregnancy of 9 months. So reduced maternal and neonatal mortality and morbidity is an indicator of the progress of the nation. Now, the developed or developing this tag is attached depending on this marker. So if there is a reduced maternal mortality and neonatal mortality, the social standing of that nation goes up in the hierarchy. So together we can work, and I am sure with the cooperation what we have established between two nations, that Nigeria and India, District 9111 and District 3170, we can definitely partner to bring about or reduced maternal mortality and neonatal mortality. We are ready always, we are ready to do partnerships, we are ready to help, we are ready to learn from you, as well as you can learn something from us, and we can carry this torch of togetherness in the future. Thank you very much. I thank you all again for giving me this opportunity, and I look forward to have more interactions with your district in days to come. Thank you very much.
Thank you very, very much, Dr. Statish, for that beautiful, brilliant, interesting presentation. My district governor was able to join just at the time you were telling us about your readiness, this end of your district, to partner with our district 9111 on maternal and child health projects. I'm delighted to even hear that. He's online, going to respond to that in a few minutes. Well, like I said, the one thing that I pick up, two things. It's a pregnancy should be by choice and not by chance. That one actually is a slogan that I think we should give to all our women. And of course, the project ideas you have shared, they're fantastic project ideas that we have saved, that we too can sell the ideas in our District 9111, and clubs can tap into such projects. Thank you once again for coming on board. Thank you that the Singapore discussion has come into reality.
Thank you very much. And if there are any questions, I am ready to answer.
Thank you. Yes, yes. We'll take the questions briefly, but let my district governor is not there yet. Okay, all right. Yes, I want to say, because I want to take the last. Oh, see, that's true. I don't know what I want to say after more minutes, so that you can just take the questions after the last presentation. Is it possible?
Yes. Yes.
Okay.
Yes.
Okay. All right. Even Prof has spoken on your behalf already. He has answered on your behalf. Okay. On that note, please let me quickly welcome. I think the profile is ready. PDG Associate Professor Stella Anyagwe. We met at the Rotary regional leaders training seminar in Addis Ababa in June, and that was where we discussed. Our discussion is also led to have been present as also one of the facilitators this evening or this morning. So on that note, I want to welcome I want to thank Professor Stella Anyagwe. Please let's have a profile, please, a brief profile.
Yeah, my PDG. Before we proceed quickly to the profile, let me quickly use the opportunity to recognize on board here. We have PDG Dele Balogun online. We have PDG Remy Bello with us, and we have the RI African Regional Public Image Committee Chairman, Rotarian Ibim Seminatari on board also, and our assistant, the Assistant Regional Public Image Coordinator, Rotarian Michael Effiong is there with us in the conference. Right to the profile of Professor Stella Anyagwe. Professor Stella Anyagwe is the honorary professor of epidemiology from the University of Pretoria in South Africa. She is listed with Who is Who in Africa, and she's a program area coordinator for disaster risk management, World Health Organization Office for Africa within the year 2012 to 2013. She was country representative for World Health Organization WHO in 4 countries of Seychelles, Mali, Zambia, and South Africa. That was in 1998 to 2011. And she served as district governor 2020 to 2022 in Rotary District 9400 in South Africa. And she covered Eswatini, Mozambique, Northern South Africa, and she, just like yourself, that was the first female DG in Rotary District 910. She was the first Black female district governor in the over 100 years of Rotary in South Africa. Professor Anyagwe Stella she's currently the Rotary End Polio Now coordinator for Region 28, Zone 22, covering Eastern and Southern Africa. That is 7 Rotary districts and 15 countries in the East Africa. May I have the pleasure to invite to present to us Rotarian PDG Stella Anyagwe. You have the floor, ma'am.
Thank you very much, fellow Rotarians and friends of Rotary. I hope you can hear me because I'm taking this call from a...
Yes, I can hear you.
Okay, I'm taking this call from a library in London because I am not home, but I had agreed to be part of this meeting, and so I did all I could to go to a public place that had Wi-Fi. And I am glad to be here. Thank you very much, my friend and fellow Rotarian, PDG Lawson, and thank you for the invitation. It is my pleasure to talk at this meeting. And I'm glad that all the professionals in maternal and child health have all discussed MCH. I will not talk about maternal and child health. I'm going to talk about, and that was the second part of our meeting, how we can increase membership with projects. I just want to go back and give us a brief about Rotary. All of us on the call are Rotarians, but it's nice to remind Rotarians where we came from. Right now, we are 1.4 million members in Rotary. That is Rotarians, including Rotaractors, given that Rotaract is now part of Rotary. We spread across 46,000 clubs all over the world. And what are Rotarians? Rotarians are a network of neighbors, of friends, of leaders, and of problem solvers who all see a world where, this is our vision, where people unite and take action to create long-lasting change across the globe in our communities and in ourselves. So that is what Rotarians are, and that is what we hope Rotary members will do. So when we look for Rotary members, everybody knows that Rotary is like a big revolving wheel. People join Rotary for various reasons and walk out of Rotary for various reasons as well. When we do exit polls of people who are leaving Rotary, you ask them, why are you leaving? Because you became a member. It's interesting to hear the responses. Many of those are that people joined Rotary and didn't exactly know what they were joining. They had a fantasy about Rotary. They saw people in Rotary and wanted to be like them. And then when they joined, they found out Rotary was too time consuming, or Rotary was too expensive for them, or Rotary was too demanding of all kinds of things. Therefore, we must be determined, we must be intentional when we look for members of Rotary. And it is a wonderful suggestion that we can use projects to bring in members to Rotary. And we have, and I'm going to talk a little bit about that. For those of you who do not remember that the first 4 men who created Rotary did not create Rotary for projects. In fact, there was no talk of projects in 1905, the 23rd of February, when they had the first Rotary meeting. 4 men were lonesome in Chicago. They were new to the city. They knew nobody. They had no friends. And they decided, with at least Paul Harris, whose bright idea it was, decided to call 3 other friends and ask them that they should meet on a regular basis. 1, to discuss how they could, encourage each other in a strange city. 2, for fellowship. And from 1905, when they met, for the first 2 years, they did nothing but fellowship. The fellowship from one person's office to the other, and that's how the name Rotary came about. It was a rotation of a meeting from one office to the other. The first person in whose office they met, Mr. Lower, he was the first president of their Rotary Club. Don't forget that Paul Harris was not a president of his Rotary Club when he started the organization. Lower was the first president of that club, and he was a mining engineer. The 3 others were Paul Harris himself was a lawyer. We had another one who was a coal merchant, he dealt in coal. And the 4th one was a tailor. And that is where, in the beginning, Rotary clubs were supposed to have classifications, which means you're a professional. We encourage different professions in the same club. And when I joined Rotary in 1995, you couldn't have more than 1 doctor in a club. I was a doctor, you had to join another club. But thank God Rotary has relaxed its rules, and you can have people of the same classification in the same club. As a matter of fact, you can have a course-based club. Everybody interested in maternal and child health could form a club. That is also positive. So this is just a background of who members are or should be. And when we are looking for members, this is what we want to look for. We tell members about the benefit of being a Rotarian, and the benefits are many. Benefits of Rotarians are many. We are there to support each other professionally. We are there to work together. And like I said, fellowship was the first thing, but 2 years down the line, in 1907, after they met for 2 years, those 4 men, and they had become more men, they decided, listen, it's now time to give back to our community. We should do something for our community. And what did they do? The very first project in this world, it's a project which was carried out in 1907 in the city of Chicago. Those men who were members of the Rotary Club of Chicago looked at Chicago, talked with the civic leaders, and looked for what the problems that they could have help solve were. And they found out that, don't forget that this is the United States in the early 1900s. They were just as backward as any place else. They found out that public toilets, what they call health facilities, were lacking. And so the very first project in this world was the building of public toilets in Chicago. That is what the Rotary Club of Chicago did. And thereafter, they said, well, this is good. It was very well appreciated. Let's continue doing good in the community. And so later on, during a Rotary International Convention, because now there were many clubs in the US, when there were 16 clubs in the US, In 1910, they had their first Rotary International Convention. And there they decided, well, we would continue doing this in all the clubs. All the clubs will help support their communities in doing projects. It wasn't until 1917 when what we call now the Rotary Foundation was created. That Rotary Foundation, which we all know is the arm of Rotary that does good in the world. That year, the RI President of the Year, Arch Plumf, took from his own pocket $26.50 and said, this is my contribution towards the creation of what they call the Rotary Foundation. We will contribute monies as an endowment fund to do projects all around the world. And that is how the Rotary Foundation started. Today, we are talking of over $1 billion of contributions that Rotarians have made towards the Rotary Foundation. You all remember the 7 areas of focus of the Rotary Foundation. Saving mothers and children is one of them, which you are doing, and we thank you for it. The 6 others are promoting peace, fighting disease, providing clean water, sanitation and hygiene, supporting education, growing local economies, and of course, the last one we just added just 2 years ago, protecting the environment. It is in the 7 areas of focus that Rotary clubs are called to carry out projects to do good in the world. Now I come to the crux of the matter. Nigeria has been honored, actually blessed, with a program of scale grant for saving mothers and children. $3 million. For 5 years, you're going to do this. We had our first program of scale grant in Zambia to fight malaria. They had $2 million from Rotary Foundation, but 4 other millions from all other people, Bill and Melinda Gates and all. They had $6 million. I know it for a fact because my home club is in Zambia. I joined Rotary in Zambia in 1995. Membership in Zambia has increased because of the success of their program of scale project. They've done so well that people who see what Rotarians are doing are flocking to join Rotary. They've got several new clubs created because people have really seen the work that Rotarians are doing. Nigeria can do same. Nigeria can do same. Because with this program of scale grant to save mothers and children, you already have facilities which came before the grant. We could have you bring in a lot more Rotarians when they see the impact of what you are doing. Let's not forget that Rotary, people join us when they see what we do. But one of the reasons, I must bring it up, one of the reasons why people leave Rotary clubs, it's because they say Rotary clubs they join do the same projects year in, year out, year in, year out, so that those who are not interested in that particular project feel left out. Therefore, individual clubs should have a variety of projects, but this program of scale grant for protecting, saving mothers and children, I am certain will enable a lot more people to join Rotarians. However, as we want to increase membership, let us not forget the 4-way test approach. Because when we invite people to join Rotary, we must be sure that there are people of integrity who will follow the 4-way test. I want to end just with some fun statistics to let you know which some of the people who have been Rotarians and who were considered Rotarians, and you will judge for yourselves whether those people were worthy Rotarians. We can't tell, but they were Rotarians. In the US, President Jimmy Carter is a Rotarian. He's still alive. President Reagan was a Rotarian. The 2 presidents, Bush's father and son, were Rotarians. And this is the punchline I want to leave with you. Past President Trump is not only a Rotarian, he was the past president of his club, the Rotary Club of New York, number 6. You make your own decisions after that. Other important people who have been Rotarians, Margaret Thatcher, PM in the UK. I'm sitting here in London right now. Bill Gates is a Rotarian. Lots of other people are Rotarians. Are these people Rotarians by name only, or are they Rotarians in action? A lot of them are still Rotarians in action. What we hope for is that we will attract people to come to Rotary, to join us as people of action so that the vision of Rotary can be attained. Because we are people with whom unite to take action to create lasting change across the globe, not only in our communities, but in ourselves. And I really do hope that this program of scale grant in Nigeria with the project to save mothers and children will create lasting change in your district. I thank you, and I will await questions on this later on. Thank you so much.
Wow, 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 wow. Let me first commend the fact that this presentation was being made out of its local base. And I can imagine how inconvenient she has found it to find herself inside the library where there was where there is a network for her to join us and make this presentation. And yet the presentation was just too fantastic. Thank you very much. You are taking also the memory lane of how Rotary itself started. And the membership of 4 people at the start, who started just because of fellowship rather than by project. And the membership actually started the issue of classification that we have in Rotary today. The first program which was executed in Chicago is out of public toilet. And of course, our Rotary Foundation started in 1917 with the first donation by Art Klump, who was 6th Rotary International President, and which today has grown to billions of dollars. He paid the first donation of $26.50. And of course, the other that the program of skills started with Zambia to tackle malaria. And that project alone led to increase in membership and formation of more clubs. And it now reminded us that we are lucky in Nigeria to have benefited from the second one, which is on maternal and child health, which has brought us together. It reminded us that only projects can actually attract people. When they see the value of what we're doing, they wish to be part of it. Leaving us with the fact that great people are the members of Rotary. Past American President, Margaret Thatcher of UK, Bill Gates, and a host of notable people are Rotarians. So why can't anybody join? Why can't all the people we have in our communities join us as we drive the vision of Rotary International? Thank you very much once again. The questions will still come, but thank you for having taken your time. You are here quite early. You will still allow us a few more minutes so you can ask any question and it's passed across to you. Thank you very much. Wonderful presentations we have today. Wonderful leaders, wonderful facilitators that have engaged us to be started at 10 o'clock. Thank you to you all. Now, we shall now take good message from our governor who has been trying. He's been having network issues since, and I think he's now on board. A pioneer district governor of 9111, Lieutenant Dr. Oluwole Kukoyi. My governor, you have the floor, sir. Your goodwill message. Thank you, sir. You can unmute yourself. It's RDG, sir. I hope he's not still having this same issue again. Oh. Because he said it should let us know when he's able to connect, and we are notified that he's not able to connect. Well, we still go on. I believe that today, sir, we shall be able to have the opportunity of listening to him. Oh, yes. Yes, can we go to take the last presentation? It's going to be our own representative from Southwest who has put together this program. You know, I said we have. Yes, please. Is it here now? Okay, now. Please join me to welcome United District Governor of 9110, Lieutenant Dr. Oluwale Kokoyi. Thank you for coming on board. Over to you, sir.
Thank you very much, my past district governor and zonal coordinator. I believe you can all hear me.
We can hear you very well, sir.
Okay, and the zonal coordinator for the Reproductive, Maternal, and Child Health program. I'm so sorry that I've not been following the program since it started. I've been having issues with the connectivity, and I've had to change from one network provider to the other to be here for a discussion on an important topic as maternal and child death, which we all know is a very important part of this area, 7 areas of focus of Rotary. I want to particularly thank those who have spoken before me, and by that I'm referring to a very respected past district governor, Niji Raji, and of course Professor Lufadeju, who has done extensive work on maternal and child health. I want to praise the sagacity and the commitment of both Rotary leaders in the aspect of maternal and child health. Well, this is a topic that is very, very germane and very important to not just to Rotary, but to humanity. We know that maternal mortality rate throughout the world
I think his network has a ceased. Hello?
Oh. Yes, my network.
Oh, okay. Let's still, and it's still online. Okay, let's go ahead. Let's pause for a while. So you follow up, Elizabeth, follow up on him so that we know when he can be back. Are you okay? Yes,
okay,
our distinguished facilitators in the house. It is not over until it is over. But I will want us to take some questions first. And we must still go back to this program of skills because it is on maternal and child health. And that is what brought us together. The presentation was cut short because we had to take other facilitators. But we must get to the end of this. We need the statistics to show everyone the success story, what has happened so far. So, but before we take that, please, I want us to ask a few questions, probably take 3 questions. So if you have questions, and by show of hand, please kindly indicate, and you tell us who you want who you have directed your question to, please. So by show of hand, let's see if you have any questions so far on the presentations that have been made. Thank you. Show of hand, please. Yes. Questions, please, or reaction, or whatever, or contributions, please. Yes, anyone can come on board if you wish to ask questions or contribute. Who do we have for the round? Okay, if I cannot see any hand up yet. Oh, yes.
PDG Remi Bello, his hand is up.
Past District Governor Remi Bello, your hand is up, and therefore you have the floor, sir.
Hello.
Yes, we are hearing you.
Yes, good morning.
Good morning.
Minute to 12. I want to thank you most sincerely for putting this webinar together. It's been very informative and interesting. I want to thank the discussants, the centers for their presentations. My question has to do with program of scale in Nigeria on maternal and child health. Where are we? What's the update? What's the progress so far? Thank you so much.
Thank you very much for Remi Bello. Probably if I have allowed, yes, if I have allowed a national coordinator to have spoken earlier, probably the question will not have arisen. But they are taking note of that because that is where we are going next now. After these few questions, exactly where we are is what is next to be discussed. So thank you for that question. Any more questions, please? Any other hand up? Okay, we will go to the program of skills. Probably that will generate still more questions. The topics are interwoven quite all right. So I know that will elicit more reactions and questions. Our national coordinator, Lou Fadeju, sir, I know you have Bumi on board. Afalabi is going to take us through the update on program of skills, and maybe you will not have one or two things to add to it again. Thank you very much. Bumi, please, over to you.
Thank you very much, district governors, past district governors, and all other eminent attendees. Kindly confirm to me if you can see my presentation slide.
Yes, we can see that, we can hear you.
All right, thank you very much, ma'am. Okay, so I'll pick it up from where Prof left off. Now we're going into the programs of scale proper and the level of implementation and some of the success stories that we've experienced so far. So this dashboard is just showing the areas where we work for the programs of scale. And that is in 4 locations. I use the word locations because FCT is not a state, Federal Capital Territory, Abuja. So FCT, Ekiti, Nasarawa, and Gombe State. In the FCT, we're working in 1 local government, which is the Abuja Municipal Area Council, AMAC for short. And then in Ekiti, Nasarawa and Gombe, I'll start with Ekiti. For Ekiti, we work in Ado Ekiti and Ijero local government areas. In Nasarawa State, we work in Akwanga and Lafia local governments. And then in Gombe State, we work in Gombe local government and Yamal to Deba local government. Now, for each of the states, I'll come back to the FCT. For each of the states, we work in 6 primary health care centers per local government and 1 secondary facility per local government. So that means in each local government, we work in 7 health facilities. So and then in each state, we work in 14 health facilities. For FCT, it's just 1 local government, so 7 health facilities. Altogether, that gives us 4 communities. Of course, Prof already gave a build-up to how the programs of scale came about. And I know eminent Rotarians here also know the process and everything. And going by the fact that over 70% of home births take place at the community, this program is purely community-based. Hence, the health facilities captured there and the communities which we work. So I'll go into the activities that make up the intervention. So one category for the activities involves training and capacity building. In terms of training, you have the emergency obstetric and neonatal care training, EMOC. You also have the respectful maternity care training. Respectful maternity care training is very important because part of the reasons why some women don't seek healthcare service at the facility is the attitude of health workers. Then, of course, we have the advanced training of MROs, MNEs, and HMIS, which Prof gave a build-up to as to how the NPCDSR policy came about. And then Rotary created the National Obstetric Quality Assurance e-platform as a local platform. So yes, the platform has been handed over to the federal government of Nigeria. Federal Ministry of Health received that, like Prof mentioned, but we still provide support in form of trainings, capacity building, reviews, which also transcend into compliance level, which I will go into later in the presentation. Then, of course, training of NPCDSR committee members. Prof earlier talked about how the verbal autopsy is being done, and then eventually it is now captured on the electronic platform, and then it's scaled up to the highest level for decision making. So there's an NPCDSR committee. And then, of course, LAC, the family planning, long-acting reversible contraceptive training, FP-LAC training. Now, before I leave this slide, I must mention that when we train health workers or NPCDSR committee members and what have you, but mainly on the health workers, because of policy shifts, particularly in the area where you have people being transferred from one health facility or the other, we wanted to ensure that, which is one of the major tenets of awarding these programs of scale, which is scalability, is adhered to strictly. Now, if you train a health worker and the health worker is transferred to another health facility where the programs of scale doesn't cover, you know that it's like a loss. So we came up with post-training supervision and mentor-mentee approach. Now, in each of the states, there's a midwife. FCT has a midwife who also serves as the chief midwife for the project. And then Ekiti, Nasarawa, and Gombe states also have one paid midwife each. So every month, they pay a visit to the health facility. That's called a monitoring visit. The essence of the monitoring visit is to ensure that the trainings that have been dispensed, like the EMOC, the respectful maternity care, and the FP-LAC training, that those learnings are being transferred to their other colleagues, okay? And also to ensure that the learnings from those trainings are being applied into saving lives and scaling down maternal and neonatal mortality, which of course we know that the overall objective of the project is to scale down maternal and neonatal mortality by 25%. And of course, when the midwives work in the state, they don't work alone. This is a Rotary project. So there's a state representative. And I know the representative for Ekiti State is online. And of course, for every other state also, there's a state representative and of course, a zonal coordinator who is a past district governor. So every activity of the midwife, of course, is done in tandem with the Rotary state representative. They work hand in hand. Like as we speak right now, renovation of health centers is ongoing, and that is being done by the state representative, of course, along with the midwife. I just thought to chip that in, but I'll still talk more about it going further. So that's as far as training and capacity building goes. Then public awareness and community information dissemination, advocacy visits. Prof talked about advocacy visits at all levels. Remember, this is a community-based project. So advocacy visits from the Federal Ministry of Health level, that's to the Honorable Minister, Minister of State, Permanent Secretary, Director of Family Health Department, which we interface closely with, more focused on the reproductive health and the health promotion divisions of the Federal Ministry of Health, all the way to the National Primary Healthcare Development Agency. Then at the state level, the state ministries of health, the state primary healthcare development agencies, and then bringing it down to the health facilities, and then of course, all the way to traditional rulers, and then the ward development committee structure. So all the way, advocacy visit is very key because we want to ensure that at the end of these programs of scale, all the gains are not lost. And if the program is being fed into this already existing system, then we can be sure of sustainability in the areas where we work. And then, of course, that can be scaled up across the country. One other thing we do, we make sure to do for each of these activities, whether trainings or the public awareness, which I've come into right now, we ensure that there is a protocol. A protocol is developed in collaboration with the authorities and the partners. When I say partners, SOGON, that's like the Society of Obstetric and Gynecology of Nigeria, SOGON, and all other key partners in the space. So those protocols are developed along with them, and then so that when it's time for scaling up, those protocols can be taken and these activities can be replicated. One of the beautiful things we've seen with doing that in some of the states we work is that the state government collected some of those protocols for some of the activities, and they've even started scaling up some of those activities in local governments where we don't work, where the programs of scale doesn't cover. Now, so that's as far as advocacy visits. And then for advocacy workshop, there was a flag off when the program was going to start. That you say was the base for advocacy workshop. There's another one being planned later in the year where all of the stakeholders will be brought together. The results we've gotten so far will be put in place, and also an evaluation that is going to go on, that is going to happen, that has already started, as a matter of fact. The result of the evaluation would also be looked at that workshop, and then of course there'll be learnings from it. Then community dialogues. Remember, this program is stationed at the community level. So at the community dialogues, the health workers that they already know, that they are familiar with from the health centers around them, are the ones that do the speaking. Of course, it's done in the local language. Topics like hygiene, nutrition, how to identify risky pregnancies, male involvement, transportation to the health center, and other attending issues, family planning and the likes, are being treated at the community dialogues. They are done at the community. Well, in some cases, they do them within the health facility. In a few cases, we've had a few cases where the traditional ruler insisted that it should be done in their palace, so that the people will understand the enormity of what is being discussed and take it seriously. And of course, focus group discussions go on, interpersonal interviews, role play, drama, and the likes. I mean, we've even had the privilege of Rotary International presidents experiencing, a community dialogue and a community outreach, which is the next thing I want to speak about. So for the community outreach, you see in bracket there, home visitation. What we have is community health extension workers, CHUs and CHIPs, are trained on various kind of interventions. When we say interventions, of course, they give out mosquito nets, birthing kits, which was provided by the Birthing Kits Foundation of Australia, BKFA. And then, of course, they also give talk about family planning and all other attending issues like that. Of course, they don't screen at home, sure that the health facilities are being utilized as they should be. We'll still share the statistics in the course of this presentation as far as community outreach goes, but we visited over 20,000 homes within the areas where we work. And then, of course, social media campaign, that is quite self-explanatory, to project what we're doing on the field so that other Rotarians can see it, and also even those who are not Rotarians can see the good thing, glean off what the last speaker said, because when they see the good that is being done through this project, that way we can get more people volunteering to come on board. Then data management, MPCDSR, community and facility e-platform management, data quality validation. That's, of course, when you get data, whether from the facility record or the e-platform I mentioned, or the DHIS2, which is the central body for the country, it's important that you check the validity, the accuracy, and of course, the correctness of the data. So we also carry out data quality assessments. Now, the unique thing we do when we carry out data quality assessments, again, putting sustainability at the front burner, is we don't just go to the facilities, do the data quality assessment, and then share the reports with the facility or the state primary healthcare development agency and what have you. No. The approach we adopt is when the personnel that is going for data quality assessment lands in the state, even before they go, they pre-inform the states. So that way the reproductive health coordinator, the family planning coordinator, the Rotary rep in the states, the midwife, and then the person who came from Abuja all go together to those facilities. So that when there are discrepancies in data, and I forgot to mention, the M&Es, of course, at the local government also are part of that team. So that when there are discrepancies, they look at what is there with the M&E person and they resolve the difference there and there. The ones that cannot be resolved on site are then escalated, to higher heights. Painting a picture of that, let me give you an example. When data is entered from the facility, it goes, of course, to the DHIS system. After a couple of months, it is locked at the Federal Ministry of Health here so that people don't go back to tamper with it. So in the event where we see those kind of discrepancies, of course, the M&E is now escalated all the way the chain of command till it gets to the Federal Ministry of Health, where they're not able to unlock the system and then open it for them to correct already mentioned. Then institutional strengthening. We have purchase and distribution of medical commodities and equipment, contraceptive commodities, including LNG IUS, which of course Rotary is the sole distributor in Nigeria, and then of course drugs. Then material supplies, treated mosquito nets, birthing kits, and what have you. Then of course, so this is just now looking at how those facilities feed into these various topics. Community level intervention. I already talked about the community dialogue and the outreach. There you see a picture of a community dialogue going on somewhere in the FCT. And then how those activities also lead to reducing the effect of the first delay. I talked about how we use counseling, how we do the community outreach, we do away with preeclampsia and eclampsia. I mean, try to combat that because we know that those are some of the leading causes of maternal deaths. Then, of course, the CMP CDSR policy, how this program also feeds into all of this, which I've talked about. We're just looking at how they all culminate here together into that. Then, of course, talking about prenatal care, again, also how the activities feed into it, community health workers doing routine home visits, community outreach, and the like. Improvement of dietary and lifestyle guidance. Remember, the price of food and commodities are quite expensive. So part of the interventions, which of course go on at the community outreach and the community dialogue, is to teach these pregnant women how they can stay healthy, be nourished, especially because of the baby, with whatever their budget can accommodate. And then, of course, in the course of this also, we inculcate birth preparedness, complication readiness. I mentioned earlier that one of the topics that is taken very seriously at the community dialogues is how to identify risky pregnancy, so that you don't have a woman saying, oh, a traditional birth attendant delivered me of my first 2 babies, so this third one is a must. And then sadly, the woman goes into complication and instances of traditional birth attendants still trying to stick it through against all odds. Male involvement also is key. We know that part of the 3 delays is delaying to go to the health facilities. Part of the delay could also emanate from male involvement. We live in Africa. We know Africa is a patriarchal society, and whether we like it or not, at the community level, we still see instances where a woman cannot go to the health facility until her husband gives a nod, even if all hell is breaking loose. So this is also a topic that we take very seriously. And I must also mention that the community dialogues will prioritize the attendance of men, because we understand the key role that men play. That's why the program is called Together for Healthy Families, not just the woman, because she can't, I mean, it's not a one person thing, it's the entire family. And of course, early identification of signs and symptoms for preeclampsia and eclampsia and referral, which I've already inculcated while talking about those activities. Then immediate supportive management during pregnant women having eclamptic fits and referrals. I've also alluded to some of this in the course of talking about the activities, and then giving pre-referral treatment to the woman with eclamptic fit, so drug being administered by only trained health workers, choose nurses, midwives, and doctors. All of these feeding into the overall objective to ensure that we scale down maternal and neonatal mortality by at least 25% in the areas where we work. And then, of course, how it leads into the reduction of the second delay, ensuring that women get care as quickly as possible. And then, of course, there's talk about removing financial barriers to accessing health services and health facilities. In those community approach that we adopt, we also encourage the men to start savings, put a certain amount of money aside every month before the woman is due to give birth, so that it doesn't come to them as a shock or quote by the time she's supposed to give birth, and then there's complaint about funds not being available. So I already went through the activities. This is just showing the activities again in a more graphic and interesting manner. So I'm going to skip through that. This is the roadmap of where we started from. 2022 preparations for the programs of scale, 2023, which was last year, where we did the flag off and a number of activities. I'm sure the slides will be shared so you'll be able to see the part of the text that may look tiny, from the baseline, equipping of health facilities with initial supply, trainings, capacity buildings, and what have you. Now, let me go into numbers, because I recall a question that talked about where we are on the programs of scale. Now, this is the EMOC training I talked about, the emergency obstetric and neonatal care training. So what you have on your screen is the number of persons trained. That's 220. And you see how we've disaggregated them by state, by category of health worker. Yeah. Then on the right, you'd see 294. And the question may be, oh, is this 294 part of this 220, or is it independent of it? Yes, it is independent of the 220, in the sense that, you recall I mentioned that for sustainability purposes, we ensure that when people are trained, when we gather people to train them on any topic whatsoever, they are mandated to step down that training at the facility. And the midwife and state Rotary rep see to it that this actually has been happening and is still happening. So the 220 you see on the left are the people that were gathered in the place for a number of days. I know the EMOC training was 5 days, a week-long training that were trained on that. Then the 294 are the ones that were trained at the health facility. So if we're going to say how many we've trained all together, that will be 220 plus 294, which will give us 514 in all on emergency obstetric and neonatal care. And then, of course, that's it's by gender, male and female. Then for the respectful maternity care training, you can also see the number of trainees so far, disaggregated this time by local government. That's on top with the green graph. Yeah. Nasarawa, you see Akwanga, you see Lafia in there, you see Ijero, Ado-Ekiti, Amak, and what aggregated them by cadre of health workers. You see, so far we've trained 146 health workers in respectful maternity care training. And remember, we keep following up to ensure that they put all of these learnings to work. Then for the community outreach / home PNC facility delivery, family planning and breastfeeding, counseling on going to the health facility to treat malaria. They don't treat malaria at home because that would defeat the purpose of referring them to the health facility. Then water, sanitation and hygiene, immunization, nutrition, and of course, diarrhea prevention and counseling on treatment to go to the health facility. So far, as at the end of June, we visited 20,204 homes. As at the time we're speaking, I'm sure that number would have changed because we want the month to end and then we will now spool it into this presentation. But this is as at the end of June 2024. Now, may I also mention that the target for this project was to visit 5,880 households, but clearly we've more than surpassed that. One of the questions that may be on someone's mind is how? So again, in the spirit of sustainability and advocacy that Prof was harping on, we ensure that we stay very close to the state structures. And so we've seen in some of the states that the state government also augments in the efforts that we are putting in for this home visitations. Hence, you see, that's why the numbers, picked up faster than it was even envisaged at the time this program was being conceptualized. Again, talking about sustainability and success story there. Then for community dialogues, so far we have conducted 176. Every quarter we do 36 community dialogues. So they are spread across the communities under those local governments close to the health facilities where we work. And in the course of that also, you'd see that we take attendance and of course mark the number of persons that are being reached by this community dialogues. I mean, well over 14,000 thereabouts that have been reached. You see us disaggregating
my brother. Hello, my brother. Just a quick one. I seems to be having some bit of distress conversations here now because we promised the participants strictly a time interval and we are almost 1 hour plus beyond that.
All right, so I'll just rush to the end in 2 minutes.
Can you just round up, please, if you don't mind?
Let me just round off in 2 minutes or less.
In one minute, really. Thank you so much.
1 minute. All right. So that's the community dialogue. What you have next is the topics that were discussed and the evaluation, the level of comprehension of the people. We already talked about the training of the data people. These are the numbers that were trained. And then, of course, the compliance level for the MPCDSR platform. When we started, you see how low it was in 2023. And that was 7.52% in terms of compliance, and how we scaled it up to over 92%. I've talked about distribution of medical equipment, and then of course, advocacy visits and workshops. And in the course of talking, you would notice that I had already thrown in some of the success stories that we've experienced. There are lots of them, as you can see, but we can't go into them again for want of time. And just capturing more of the success stories in all of this. And this picture was taken at the flag off of the programs of scale, the Together for Healthy Families in Nigeria programs of scale. You see a lot of our PDGs and eminent Rotarians there. You see past District Governor Lawson also there in attendance, as well as the Rotary Club in Germany, which partnered with Nigeria to bring these programs of scale to being. Well, for want of time, this was supposed to be a video encapsulating everything I've said, but there is no time for that, so I'll just skip through it. Thank you very much.
Yeah, thank you so much for that.
Thank you very much, in actual fact, I know that these presentations can actually be put even inside. I mean, on the online as well as we are picking, you can put them there. Because I know, particularly when data is involved, people will still want to go back and refresh their memories and even learn more from all the data that are presented. So I want us to put it inside this box, and then we can take the Southwest, the only person representing us in Southwest, to take his presentation, and then we go back finally to round off.
5 minutes.
My zone coordinator, thank you very much. I think I thank you for the time. What we have done is to write to the governors of all the districts in Nigeria to give the program of scale 2 hours to present only program of scale.
Exactly.
And that the government have received letters now. They are supposed to give us the convenient date in the month of August to do that.
Aha. Okay, thank you very much. In fact, we will have ample opportunity and time to actually deal more, as this is a topic that everybody is interested in. Thank you so much, Additional Coordinator, for the presentation. Like I shared with Dr. Loide, I said, in fact, it will have been purely program or scale program. They will have had even yes, so much more time to use on it. So on that note, let us thank you very much, Mr. Afolabi, again for the presentation of facts and figures. Thank you so much. Finally, we are going to take the coordinator and membership chair for Ekiti State, who is the only Southwest state that is being represented in this program of skills. And therefore, I have the honor of presenting the PhD Ibitoye, Dr. Ibitoye Samuel. So can you read his profile briefly so I can make his presentation? Thank you.
PDGs, Dr. Ibitoye Oluwabumi Samuel is a dental surgeon at the State University Teaching Hospital. He's currently the Director of Planning and Research at the Statistics Hospital Management Board in Ekiti State. He's a past president, Rotary Club of Ado Ekiti, District 9126, and a past assistant governor too. He's a state coordinator and Rotary representative for RMCH since inception. Today, he will be speaking to us on the success stories recorded on the program of scale in Ekiti State, Southwest Nigeria. Dr. Bitoye, you have the floor.
Thank you very much. I hope you can all hear me.
We can, yes.
Audible enough. Thank you very much. Greetings to all our leaders, all our PDGs, DGs, and leaders in the house. Well, I believe the program of scale has come to stay, and with lots and lots of success story to record. If you remember, Bumi Afolabi has actually highlights most of the success story. However, I will just chip in just to further buttress few of the points that it actually go too much into based on because of the time. So I can say largely that the Ekiti State experience has been fantastic. Of course, not without its challenges anyway, but to a large extent, I think we have done very well, especially with the trainings and the likes, which cut across virtually all health cadres. We train the doctors. There's training for the MIE, that's monitoring and evaluation officers, so that the data, as highlighted by Prof. Lufadeju, is actually edited and corrected. Not that they just module things together. And the fact that at the community level, even this data level, as I highlighted earlier on, that have it at it's only involving the family. It's only involving the families that are involved and maybe the facility. And once they take their dead body away, everything, the information died there. However, with the program of scale and giving them the nuclear platform to make sure that every event is actually reported, and then the cascade of events takes place. At the same time, we talked about the public awareness, advocacy visit at all levels, from the federal to the local level, to the primary healthcare centers as well. We also have community dialogues at the palaces. Actually, we do it at the palace, at the same time we do it at the community. When we do it at the palace, the king gives directives so that every member of the community will know the depth or the weight, how weighty the event at hand that we're talking about, RMCH, is. And so everybody must show up. And then even to now further escalate that in a situation where we still found out that some are still missing, no problem. We take it to their doorstep. We take the community dialogue to their doorsteps. That's another angle to that. And for the community outreach, we have myriads of activities and let me put it as a mini training in form of advice that we give to the people. We do the family planning. We talked about nutrition. We talked about quality obstetric care, and then for the quality obstetric care during the antenatal care that the women must come out for. Then we talk about the transport of our mothers to the health facility in case of sudden emergency. Then we also talk about hygiene, basic hygiene. So we talk to the families along this path. By the time, especially during the time that when we take the program to their doorsteps. So this is what led to improved referral system in Ekiti State, actually, because Professor Olufadejo has visited Ekiti State. In fact, I think I've lost count, but at least I can say from last year till date, he has been in Ekiti over 6 times, just being moderate with my count. So in furtherance to this, we have gone ahead to form what we call Rotary Community Corps. This consists of the locals, especially their high chiefs at the palace, especially those that are show interest and are willing to be part of us. So we get them together to form Rotary Community Corps at the two sites where the program of scale has been implemented, that is Ado Ekiti as well as Ijero. And so you find some of these high chiefs being ready to put down their old Mercedes Benz to say that in their own community they don't want anything of such to ever occur again. Hence, they volunteer to put their car down. In Ijero presently, I think there are about 28, while in Ado Ekiti we have about 35 of them. I believe our prof would have been added to their platform so that you can see what they are doing. So by and large, the Rotary Community Corps is now functioning in these two sites. And so I believe transport of our mothers to the facility will not even be an issue because that has been taken care of. Another part that I want to just chip in is the fact that government now have been made to, even the program officer has visited Ekiti severally, and we make advocacy visit to the commissioner severally as well, the permanent secretary of the Ministry of Health severally, just to get them acquainted with what we're doing, and then to talk to them about sustainability plan. Because by the time the program is rounding up, what is their participation? And they've come up with ample events that they are going to take up. For example, even the community outreach, we've talked about it, and that's going to be taken up. The referral system, even working with the Rotary Community Corps, and then making sure that their transport to the community, to the facility is hitch-free. So those are the major highlights. In summary, our success story stems from the above points that have been highlighted, and the willingness on our part also to adopt change, mainly as introduced by Rotary Club. I would like to appreciate each and every one of us for just these little tidbits that I'm able to chip in. Thank you for the opportunity. Thank you very much.
What you have put in is not little. What you have put in is massive.
Thank you, ma.
5 minutes that you have spent, you have provided the information that we require to give everybody listening about what has happened in our own Southwest. And recall that even other states in the Southwest, we have decided that we should be on the same page in all the activities we do. Ekiti State is the only one representing Southwest in program of skills, but issues of maternal and child health, we said all states in Southwest should be on the same page in terms of programs and advocacy. Thank you for your presentation.
Thank you very much, ma'am.
And we're now saying that we want people to join us. That is why we are here. So join us so that we can be many in our bid to reach out to all the looks and cravings of our communities and do advocacy education, and also monitor situations that we have on ground so that we can reduce maternal and child mortality. And we said we are going to have membership application forms, which once developed will be sent via links by each of the state coordinators to all the platforms that we are familiar with, and even through the social media. So that people, like I said, it's only for Rotarians, Rotaractors to be part of this movement. We also embrace non-Rotarians, just like this Rotary Community Corps. So thank you again for that. And I think we're going to use, well, I will still appreciate all the speakers once again. I will just go to almost the final part. Even here we have other state coordinators. We have the Lagos State coordinator here with us, Mr. Balogun. But before we go to the vote of thanks, I know there are many papers who have 5 papers presented, which participants here and even those who are not here would like to share in. So we'll be very, very happy to have them. If they can be shared on this same screen, on this same page, we'll be so delighted to have them. However, if we cannot have them now to post, and we still want them to get to the generality of the people, and we can still do that via WhatsApp medium. So do we still have questions, maybe 2 to take from our participants in the house before we round off finally?
My zone coordinator.
Sir. Yes, sir.
We are going to discuss at the committee level.
Okay, sir.
To appoint you as the National Director for Membership Development for RMCH. In addition to your responsibility as Zone Coordinator for RMCH for Southwest. I think you have done a very good job, and we are very proud of you. Thank you.
Well, thank you very much, sir. Thank you very much for the compliment. Thank you so much. So if you have no more questions on board, let me thank Dr. Loyede for...
There's a hand raised up.
Oh, yes. Yeah. Oh, Oroluwa Israel Ojo. Please, you have the floor. You have the floor. Thank you. You have
All
the
right.
floor.
Thank you so much, Ma. Good afternoon, PDGs present. Good afternoon, Rotarians. Good afternoon, everybody present. So I would like to first of all appreciate Rotary Club for the good work we are doing in improving maternal, newborn, child health outcomes, across the world. And when someone, I've forgotten his name now, talked about MPDSR, I know that Rotary had supported MPDSR, even the NOCA site, to ensure that there is auditing of deaths that happen in the various facilities, and to ensure that we reduce the number of preventable mortalities in the various facilities. I would also like to say that this is just a comment. I would also like to say that in low and middle income contexts like ours, or if I could say developing countries like ours, we have also realized, studies have shown that much of the data on mortality reported are coming from health facilities, and we don't have a good structure for reporting mortality events that happen at the community level, And we know that in countries like ours, like Nigeria, we have so many mortality health events happening in the communities. In Nigeria, over 60% of deliveries take place in the communities. And when I mean communities, I am referring to traditional birth attendants, I'm referring to faith-based homes, I'm referring to even auxiliary nurses. And because we don't have a system for capturing data from these communities, then where there is no data, when there's no data, nothing is done. It is not documented, it is not done. And data ensures you have evidence-based decision-making. But when there's no data to even show the mortality events happening at the community level, then there's no way policymakers can make decisions to reduce preventable mortality across the spheres of maternal, child, perinatal, space. So I would like to say that if as Rotary Club, we can also expand into community MPDSR, which is a quality improvement initiative. And we already have the system, we already have the experience in engaging communities. So I think this is a good way to also see that we reduce maternal and perinatal death mortality and all. So talking about Mr. The communication, Afolabi, thank you, ma'am. Talked about, building the capacity of healthcare workers. And I would like to say that, some certain healthcare workers cascade trainings to other, healthcare workers who were not present at the state training of trainers, if I can put it that way. I would also like to say that, and he talked about sustainability, which I believe is key, is pivotal to ensuring sustained impact and outcomes. I would also like to say that if we can have so many mentors, not just one Rotarian, who oversees, this is a mentor who can, ensure there's peer-led learning amongst the people that are trained and those that are not trained, so that this can also ensure accountability and sustainability of the intervention. My last question is, how do we measure the outcomes of these community dialogues? I know we know the number of people reached, but how do we measure the outcomes of these various activities that we conduct at the community levels? Over and thank you.
Thank you very much.
Please, coordinator, please allow me quickly to respond to Mrs.
You will respond to it, sir. I want to even comment. I know you are the one that will answer them. We don't have the capacity to do that. I just wanted to say that he didn't only ask questions, he commented, he made observations, and that you are here with us to tell us or to expatiate on exactly what she has said and to throw more light.
Thank you very much. I'd like to commend her for asking the question. That is the reason why I told you that we need a webinar for program of scale on its own. We have a very robust data capturing system under MPCDSR at the community level through what we call verbal autopsy. It's a completely intricate system working through ward development committees that are already there. It's already in the bill that we sent to the Senate that is going to the House of Representatives. It's the first time we have that kind of system in the country to capture facility and community data without any problem. That is going on at the moment. But I can understand that the questionnaire, Mrs. Ojo, is not very conversant with our activities, and therefore we should provide them with the opportunity to learn what we are doing and to understand what we are doing. At the moment, there is a structure, very robust structure that moves data from the household to the community, to the primary care centers, to the local government, to the state, and to the federal government, structured. The only aspect that we have not added to MPCDSR is the private sector, which we are now working on to put private facilities under MPCDSR. So I think that answers the question. The other issue that you about community dialogue,
mentors or something.
No, we have what we call mentee-mentor. There are, we have all kinds of innovations in the program of scale that we didn't have time to expatiate. There's mentee-mentor. This is somebody who is the senior provider in a facility or in a community who is mandated to train others. And this is structured training to supervise the training that they have been given and to report to the state reproductive coordinator, and they are certificated. The certificate of every of our trainees come signed by Rotary, the Federal Ministry of Health, and SOGON, Society for Obstetrics and Gynecology. On the issue of quantification of responses at the community dialogue, again, it's structured. We have structured questions that are asked by participants by show of hand, and the result is on the platform. The platform has what we call recording of maternal death, review of maternal death, family planning use, community dialogue, and equipment rating. Equipment rating goes to facilities to check which equipment is working and which is not working, which is obsolete, which will be removed or replaced. So we need a lot of time to really go into it in detail. But I thank Mrs. Ojo for the question. Thank you.
Yes, sir. You have taken it well. You have addressed it well. I'm sure when a program is going to be held, she would definitely be part of it. We will encourage her the way we're going to publicize it, that she will know that's going to happen, so that she can also be part of the program when that time comes.
Yes.
As for the presentations today, you want to say something?
Yes, I know. Just in addition to what Prof has just said, that what we are doing in Ekiti State is that we even make sure that all the faith-based home, the TBAs, that's traditional birth attendants, and the likes, we put them together, and we even give them incentives for reporting, incentives for referral when they come to them, because we know they go, because of these people have been at the community level for time immemorial. So because of that, we also found out that people have belief in them. So since people believe in them, no problem. But we just try as much as possible to encourage them. We train them as well, get seasoned O&G specialists to train them, and then to let them know where their efforts should end. So what we now do is we now inform them, we even tell them, and we encourage them that when you refer, you have incentive for that. When you, whatever activity you are doing to support this program and making sure that we have safe motherhood, then you will be adequately compensated. We even invite them to the Ministry of Health for further morale boosting by the commissioner in Ekiti State. So that's how far we are doing in Ekiti State. Thank you.
Fantastic. Fantastic. We are proud of you. We are proud of you, Dr. Victoria, for the good job you are doing and for representing Southwest very effectively. Thank you so much.
Let me also just chip in one or two words there.
Yes. Okay.
Yeah. Now, even the program that is ongoing, the Little Steps Big Help, has realized the importance of TBAs and other established non-orthodox maternal caregiver. And we bring them on board in everything we've done. And I noticed that Lagos State government and Ogun State government too are really giving them sense of belonging. Because if we don't, we will never get anything. We will keep concealing every information that they have. So I think Joe is coming up. States are beginning to appreciate that fact. And if we maintain this trend, we see that reporting will not be a big issue in the near future. Thank you so much.
I can see the hand of PDG Adeniji Raji. Thank you for staying with us throughout the program, sir. So over to you, sir. You can unmute yourself, sir.
Said that our outreaches are bringing in TBAs, and as you are aware, many of the states also are training TBAs to be more medically compliant, and also telling them if you try to deliver a woman beyond certain number of hours, you should straight away take the pregnant woman to the hospital. So Lagos State is training the TBAs, and they also have unions to monitor each other whether they are doing some malpractices in their TBA work. So we are fully involved with them in our outreach. But most importantly, Dr. Ojo is a member of Root Club Bagada, and is a member of the Maternal and Child Health, the Little Steps.
Okay.
Of the Little Steps. So I think she can do it in other areas too. Thank you.
Okay, thank you very much, sir. Thank you very much, sir. So may I now pass the floor to Rochayemisi Balogun, the Lagos State Membership Chair and Coordinator. So please give the vote of thanks, and we can now close this beautiful conference and adjourn it till another day. Over to you.
Okay. afternoon, Ma. Thank you very much to all our revered PDGs, especially those that stayed to the end. We really thank you. Actually, Rotary is doing good, and this is a sign that we are really doing good. And we want to thank also all the participants and the presenters. It's really educating. And although the time is cut short, but I'm sure we're going to work on it because this is the first one we're doing, or we'll do better next. Thank you very much, all the PAG, the AGs, the Rotarians, and our guests. Thank you very much for being part of this.
So thank you. Thank you very much for that. And on that note, I also still want to add to the appreciation for Professor Adeola Fadeju, PDG Nijiraji, PhD Dr. Satu Damanka, PDG Professor Stella Anyagu, PhD Ibitoye Samuel, and of course our own PhD Dr. Femi Oloyede. Our governor, who incidentally still could not, and for the 1 minute he spent with us, we still appreciate him. So on that note, I wish to oh, my PDG Remi Bello, PDG Dele Balogun, happy Mike Effiong, then the Rotary Coordinator, Public Image, Ibim Semenetari, I hope I got the name correctly, and all our Rotarians who have joined us in this 3-hour program. You can't believe it. We have spent 3 full hours, but it is 3 full hours worth spending. Very well. So this
thank you very much to our PDG Omotunde Lawson for putting all this together. We are grateful.
Thank you very much. Can we please recite the national anthem? Let us close formally. We will recite it. 1, 2, go. Nigeria, we build our own
and tongues, in wisdom.
Nigeria, I thereby declare the seminar closed. Thank you very much, and God bless you all.
Thank you
very much.
Thank you.
Bye-bye.
Thank you, everyone. Over.
Thank you.
Thank you. Plenty love.
Thank
Thank
you
you
very much.
and thank you, Femi.
Yeah.
Thank you.
Bye-bye.